To remind you that today our objective is to increase knowledge regarding use of telehealth during the COVID-19 pandemic. Next slide, please. I want to take just a moment to introduce you to our panelists. Today we have joining us Dr. Michael Chamberlain. He is the managing partner in a non-pediatrician 3-office practice in Cincinnati. He serves on the board of Ohio Valley Primary Care Association, which is a clinically integrated IPA whose goal is to improve the care for all children in the Cincinnati area. He is currently a member of National AAP's Payer Advocacy and Advisory Committee. Dr. Chamberlain does not consider himself an expert in anything, just a pediatrician that tries to work hard and do what's best for his patients and his practice. Dr. Sarah Adams is a pediatrician with Akron Children's Hospital Pediatrics in Hudson, Ohio. Working as a pediatrician for over 23 years, she loves to promote healthy lifestyles in children and adolescents and is the medical director of the Ohio AAP's Parenting at Mealtime and Playtime program. In addition, she serves on the Ohio AAP Nominating Committee and Foundation Advisory Board. Dr. Adams enjoys teaching residents and medical students, writing for Inside Children's iGrow, Cleveland.com, and other media e-newsletters. She is also passionate about improving the mental health of children and adolescents by teaching others how to improve families' use of media and bullying prevention. She is the mother of 2 boys, Gabriel and Benjamin, and lives in Hudson with her husband, John, and their 2 labs. Dr. Denise Warwick is a primary care pediatrician in Anderson Township, a suburb of Cincinnati. She is the Associate Medical Director for Pediatrics for TriHealth. She emphasizes preventative care measures in her practice, including regular well-child visits and immunizations. Partnering with patients and families on shared decision-making, she works closely with families to educate them on medical conditions or treatment plans that may affect their child. Dr. Warwick also enjoys teaching medical students and residents and is active in various advocacy efforts, both in her community and statewide. She serves as the co-chair for the PA4V, Parents Advocating for Vaccines group. For the Ohio AAP chapter, she serves as a delegate at large to the board of directors and has served on the nominating committee. Outside of her practice, Dr. Warwick enjoys spending time with her husband, Steve, and their 2 young girls. Dr. Brad Lucas is joining us today as well. He is the Chief Medical Officer for Buckeye Health Plan. He is a board-certified OBGYN with 14 years of executive-level managed care experience who is committed to bringing the strengths of payers and providers together to deliver efficient and effective health care. His expertise is critical to the development and implementation of programs that improve clinical outcomes and ensure high-quality care across all medical conditions for Buckeye members. Before joining Buckeye Health Plan, Dr. Lucas ran a large OBGYN practice. Dr. Lucas received his medical doctorate from the Medical College of Ohio and his Master's of Business Administration from Baldwin Wallace University. He conducted his OBGYN residency at Johns Hopkins University and completed a fellowship through the American College of Obstetrics and Gynecology. Dr. Lucas recently finished serving on the executive committee member of the Ohio Collaborative to Prevent Infant Mortality. He is active in helping Ohio leverage evidence-based models of community coordination such as Pathways Community Hubs. He is a National Advisory Council member of the Pathways Community Hub Institute. And next slide, please. 2 of the pre-submitted questions that we received were around advocacy. One was around what the chapter is currently doing for continuation of payment for telehealth services in primary care after the emergency order has ended. And then also how the Ohio AAP is advocating for well visit codes to be reimbursed as a virtual visit. Next slide, please. We're very grateful today to have the chapter CEO, Melissa Worvey, with us today, who is going to give us a quick advocacy update. Thanks, Melissa.
Thank you. Good afternoon, everyone. I apologize in advance if you hear dogs barking or children doing their schoolwork as we all sort of plow through this right now.
Is anyone else not hearing Melissa?
I hear her.
Okay.
I can hear her.
All right, then I will just keep talking and hopefully Kristen will be able to hear me at some point. I just want to address those first 2 questions that we did receive. I think they're critical questions, and I know a lot of members have reached out privately and asked those of us. I think first of all, as you've heard, I think many times now from Dr. Acton or the governor, and now we actually even heard it today from the director of Medicaid, Director Corcoran, that telemedicine certainly is here to stay, most likely in some capacity. I'm not sure exactly what that looks like, and I think the chapter's biggest focus has been telemedicine when appropriate. So we're hearing a lot about med checks being an appropriate use of telemedicine, some sick care as well, and really looking at what that does in terms of providing increased access to families who might not have been able to get in for appropriate visits. At the same time, we are really concerned about making sure it's quality care. So a lot of people have asked about well-child visits done virtually. Should we be looking at that? Some states have gone in that direction. At this time, the state of Ohio is really pushing instead to get patients and families back into pediatricians' offices, and it's going to be the chapter's number one focus at this time. And I think the other piece around telemedicine that we always have to focus on is just the payment parity issues. We want to make sure that if we are moving down that road, that there's payment parity. We are hearing that's happening with the Medicaid managed care plans. We haven't had enough feedback yet from some of the private payers, but we will certainly continue to monitor that for all of our members. When we originally came out with the concept around doing these webinars for our membership, we talked about talking about telemedicine as a priority because we were hearing that from our members, and then talking about the CARES Act. I think a lot of you have heard many things about that. I hope that many of your practices, if you're in a private practice setting, have applied for PPP support from the federal government. That is, a loan forgiveness program. We know many people were able to get it, and we also know many people were unable to get it just because of the timing. We are hoping that in the next few days, the federal government will continue to move on that and actually put more funding back into the small business loan program. So hopefully if you have it on an application and you haven't received financial support from the government under the PPP, the Payment Protection Plan program, that you will in the future. So we will continue to advocate for that. National AAP is also advocating for specific relief for providers of Medicaid and specifically pediatric providers. This would be similar to what happened in the Medicare population, where practices were given a lump sum payment a few weeks ago based on their Medicare patient population. So we are actively advocating for that on a federal level as well. And then I think, finally, you will see a messaging that comes out later today from the Ohio AAP. We are all about pushing for making sure that families are back in their well visits. We have a new hashtag we'll be rolling out, hashtag Safe Feeds Healthy Kids today. There'll be daily social media posts. These are posts that you can share with your patients and families. We will be advocating with all of our partners to reach out to patients and families to make sure that they understand your pediatrician's office is a safe environment. We want patients coming back into the office. We want to make sure that our immunization rates do not continue to decline. We're seeing up to 40% rate decline in some areas, such as like the HPV vaccine in particular. So we want to make sure that we're getting patients and families back in the door. So we'll be rolling out that campaign. We have a lot of great partners with us. Dr. Acton pushed our talking points yesterday in their press conference and really highlighted the work that we're trying to do with everyone. So that's really where we're focusing most of our advocacy efforts. And I got a couple questions this morning from some members around immunizations and what will we be doing in the future. I think all of you know we've been pushing for a long time to improve immunization rates in Ohio. That might include actually looking at the immunization exemptions that exist in Ohio. We are one of the only states that still allows for that. Our legislature has been not too receptive to the concept of getting rid of the philosophical exemption, but if I think this pandemic shows us anything, it's the importance of vaccinations for everyone. So be looking for that as well from an advocacy perspective. And I will turn it over to our next speaker.
Wait, before we move on, Melissa, there was a question in the chat box if you wanted to, another panelist. If the Ohio AAP has an opinion on whether a standard EM code can be used during a telehealth visit when the patient is not there, or must a phone code be used?
email could be used for television. I think this was a discussion we had offline a little bit with Dr. Lucas, so I'm going to punt it to him if he wants to. He might want to wait till he's up to talk about it, but I know he sent us out a note about that.
Awesome. Thank you.
Thanks.
All right, yeah, and Olivia, you can move on to the next slide, and then we will turn it over to Dr. Adams.
Okay, hi everyone. Yes, we'll address that question for sure later, and so we don't want to make you feel like we're just passing over it, because that's actually a very good question. So why telehealth? You know, we were some offices were already doing this, especially in some specialty offices, but you know, the U.S. basically had a very rapid healthcare response to meet the needs of our patients. And so quickly, providers all over the state of Ohio started to facilitate telehealth rapidly into their practices so that we could meet the needs of our patients and our families, so we could deliver care where they are, right? They're afraid to come in. They're avoiding the offices, especially in the beginning. They don't want to. They're afraid of exposure, and although we're trying really hard to remind them that we are doing what we can in order to make them feel safe, to make them feel welcome, that we're doing everything we can in person, we're also able to do some you know, do the telehealth so that we can continue this care, so that we're still meeting their needs, making sure their medications, et cetera, everything, because we don't want to miss these opportunities. And there's a lot of advantages too to the telehealth. And now that we've doing this, and hopefully many of you are already doing it, is that we find that they're actually very comfortable with it. Many of our patients and families are already getting used to using video and audio as a way to communicate with people socially, as well as now in healthcare, which is pretty cool. Teenagers especially are used to technology and may actually feel more comfortable in this kind of setting versus actually coming into the office. It's also a great way for us to be able to assess the child or the adolescent in their own home setting, or where, you know, in that kind of setting, which I think in some ways can be challenging to really understand when we see them in person in our office. So there's a lot of advantages, and I think we have to look at the positive side of it too. And so I think that, you know, we're meeting their needs, we're not delaying care, and we're making them feel more comfortable in the situations that are appropriate. Go ahead and advance the slide. So choosing a platform can be very confusing, and, you know, HIPAA, prior to all of this, there were a lot of regulations and laws, and the Office of Civil Rights prior to this, you know, really was held us accountable for what we could use and what we couldn't use. And I'm not saying that that is not still enforced, but they are, you know, through this remote communication, they are realizing that some situations may not be fully compliant. And so that you might hear some buzzwords, things like non-public facing, things like public facing, things like in good faith. So it's very important that we review some of these things. So the HIPAA compliant platforms include both audio and visual. It could include telephone visits. And we need to understand the difference between the two. And we're going to talk about how we can bill and code for those for sure. But the OCR has waived some of these potential penalties because of the non-HIPAA compliant platforms, and saying that as long as you're using it in good faith, then, you know, we believe that that there won't be penalties. So what are some of the things that we would consider what we call a non-public facing? So basically, this is a remote communication product that allows us to have a communication with another person, with another party, but it's non-public. So it's remote, and it includes things like, Apple FaceTime, it includes Zoom, it includes FaceTime messaging, video chat, Google Hangout, DoxyMe, WhatsApp video, Zoom, Skype. There's other common texting applications such as Signal, Jabber, you may have heard, again, WhatsApp, iMessage, but these are end-to-end encryptions. These are things that our patients, our families have to sign into. They have a login, they have passcodes, there is security, and this is what's important. They're non-public. In contrast, public-facing products such as TikTok, such as Instagram Live, such as Facebook Live, such as Twitch or public chat room, these are not acceptable platforms. These are remote communications that can be open and are not secure, and they're designed to allow for a wide, indiscriminate access to other people. And so those are not to be used at all. And so HIPAA basically said that they entered into some business agreements or, business associate agreements, or what you might have seen as BAAs. And they've created some provisions with certain products. Now, they're not in general saying that they're endorsing these vendors, or they're, specifically, telling you this is exactly what you need to use, but they're just, offering these as guidelines and saying that that there may be technology that they feel is HIPAA compliant, but there could be other technologies as well that are available that are still HIPAA compliant. The other thing in choosing a platform is you need to make sure there's good connectivity, you want good sound, you want good video, all of these things are also very, very important. Now, those HIPAA BAA vendors or video communication products that I mentioned, they could be examples are things like Skype for Business, Zoom, Microsoft or WebEx, meetings just like we're doing right now, GoToMeetings, etc., Doxy.me, as I mentioned as well, Zoom for Healthcare, and there's a number of others. But you also want to make sure that, if you are employed, that, you also discuss this with your particular employment as well as your hospital. Go ahead to the next slide. So the question was, what application is being used that is safe and secure? And so like I said, I did mention some examples when I was presenting. And again, I think the most important thing to remember is the buzzwords non-public facing versus public facing, and then, reviewing, is this a HIPAA BAA compliant video communication product? Would anybody else like to, in the panel, like to offer their answers to this question? I can tell you we use Jabber as one of our applications in order to secure our phone numbers, for example, if we're calling patients so that they are secure, so they don't see our personal phone numbers. So that's something that we use as a security for us as well. So Jabber is an application that we use in our office, so that when we call, basically what they see is the number to our office. They don't actually see our personal mobile phone number.
This is Denise Work. We use something similar to the Doximity dialer, which if you have the Doximity app, you can do as well too. So similar to the Jabber.
And then most of our telehealth visits, just as an example, is actually through our MyChart in Epic. So that is also, if it's nice to be able to do it directly through EMR, because then you can also, see the chart, review the chart, etc. And that's, has video and audio capability. So we get the best of both worlds. Okay. Well, if there's no further questions, then I'm going to go ahead and pass the baton over to Dr. Ward.
Thank you, Sarah. And Dr. Peltier just chimed in on the chat box too about the Doximity dialer also having a new video capability too. So I can't speak to how it works. I haven't had a chance to use it. I had heard initially that some of it, the clarity on the video wasn't so great, but it's definitely another option. So as far as office workflow, and that was, Sarah did a really nice job of explaining the different platforms and kind of capabilities based on each of those. And I think some of it is more too, depending on if you're a private practice of a few docs versus working in a healthcare system. I know, certainly we've had a little bit more flexibility in the past few weeks, knowing that telehealth is a new a venture for most of us. And, most of our employers have been a little bit flexible. I know I work for a large healthcare system that's on Epic, but I think even though our Epic has capability with Zoom, we're actually doing some whether FaceTime or the Doximity versus the Zoom application. I think that's nice for now. And again, as telehealth continues into the future months to years, I think that may be a little bit more nailed down as far as provider preferences or, system preferences as far as, what is recommended. So as far as office workflow, and again, this is kind of office dependent, individual dependent. And I think as we're all getting a little bit more practice, we're getting a little bit more used to the different platforms and how they function. So I'll go through a couple examples. So scheduling visits, some of this onus kind of really is on the staff members that are doing this ahead of time. And I think, from hearing just from my husband is also a primary care pediatrician in the Northern Kentucky area, and how their schedulers do it versus how my schedulers do it as well, it can vary quite a bit. So I think, some depend on, are people collecting co-pays ahead of time? Are, people doing the visit and then depending on a billing department to contact the patient afterwards? And I think that definitely factors in as well. So in addition to scheduling, we also want to make sure that you're getting reimbursed for those as well. The other thing would be is virtual waiting rooms. I can speak to some of the platforms that we use. So FaceTime, obviously, there's no waiting room. So you're there, you're connected with the patient. Again, it's one of those things that depending on the technology you use, it can take away the anonymity by giving away your cell phone number. One of my partners actually is saying that she purchased a phone just for using it. And so that's how she's getting away with it, saying that it's not that. But as far as other things, the Doximity app actually is, I think, of the ones that I've used, is the most slick as far as having a true virtual waiting room. The patient is sitting there, and it actually shows you how long they've been waiting before before you click into the visit. And then it also times the amount of time you're in the visit with the patient, which is helpful for the documentation piece, which I know Dr. Chamberlain will mention shortly. That is a very nice capability. And then the third platform I've had experience with is the Zoom. And that one, it does communicate with Epic depending on licensure. If you're doing it through that way, you could also do just the regular Zoom application. But again, you don't have the capability of having a virtual waiting room. But you can also text links to or send email links to families about the Zoom calls too, by using the little exclamation point in the left-hand corner of the Zoom application, which can be helpful too. So, all right, next slide, please. Okay, so types of visits. And again, I think we're all kind of waging out in this new territory to figure out what works best in the video visit world versus in telehealth versus what does not. Some acute care is really well suited for this, something like rashes. I found that I've had a lot of people coming in for rashes or, wanting to do video visits for rashes. And I think it actually works pretty nicely. You can get some nice exposure. I think one challenge is, in more sensitive areas, just trying to keep the patient as covered as possibly can, just to kind of keep their modesty is important. The other thing too is the proper lighting for that. So I've told people, and I've had some colleagues that have recommended going into the bathroom or the kitchen where the lighting is the best. So you're actually able to see the rash a little bit better. Nice. Cold symptoms, it certainly is one that can be helpful. The biggest challenge, especially in pediatrics, I think, is that you can't get a really good ear exam just by looking at a patient. And that is sometimes a lot of time what we're wanting to see. I've had a lot of parents suggest or wanting to do sore throat visits and things like that. And, it's just, sometimes it's okay to get a good look, but other times it's not as well. So again, I think that relies on provider preference. I think really where this is well suited the most is really in those chronic disease follow-ups, like your ADHD visits, your behavioral health visits. I think parents have really been pleasantly surprised about those. They like not having to leave the house, not getting any kind of risk as far as infection exposure. And you really can do a lot of it aside from, a blood pressure or a weight check by phone. I've even had some parents that, say, hey, can you stick Johnny on the scale, while you're there just to see what his weight is today. And then, that's an additional vital sign you can document for your examination there. The other thing is to, home blood pressure and things like that available. So those are things you can also have in your back pocket to use if you need to. Asthma is nice too, as far as asthma, patients are those at high risk at this time. And so, keeping them out of the office if we possibly can is really helpful, especially now that we're in the spring and, we're seeing a lot of kids that are having asthma exacerbations due to changes in weather and allergy symptoms. And then this last bucket here of the well care. So as Sarah and Melissa had mentioned previously, we're not doing any well care currently, it's not currently approved for payment in Ohio. And so, we're still really encouraging those patients to be in the office so we can A, lay eyes on them, and then B, make sure they're getting their immunizations and other preventative screening in the office. So we're able to really, check on, development, eye screening, hearing screen, those kinds of things. Next slide, please. And then communication. So this is a hugely important piece. So, I feel like we've kind of been in a vacuum and for the past 6 weeks as far as, access to our patients at times. And I know a lot of the people around the state have been really doing an excellent job of trying to reach out to their families, whether that by social media posts or, contacting them directly by phone. And those are definitely good forms of communication. I think, so if you're not really big on social media, sometimes, different EMRs have capability of contacting patients. I know we are on the Epic platform as well, and there's a way to do like a mass MyChart message to families that are signed up to MyChart. And we've used that capability a few times to really tell people about, age groups of patients that we were seeing and kind of best ways to contact us via telehealth or video visits. Emails are another capability too, if you have access to patients' email addresses as far as contact information. But I think, those are the main forms of communication. Some practices have set up like an actual a website for their office, which is really nice. And that's a great place to store information. And I think kind of a good set point for us to think about moving forward for really everyone to have some type of presence on, the internet so that it's a good form of communication for patients and families. Next slide, please. Okay, and so here we are with questions, and I know there's some in the box as well. So, so how do you deal with a diagnosis via telehealth during COVID-19 for conditions better seen in person? This is Pandora's box, right? So it is really challenging to, for, like a presumed otitis media, especially in those older kids, like the 7 and 8 year olds that, Johnny always gets ear infections and he always presents like this and it's just on the right side. I know, in my practice, I think as long as the kid is very low risk, we're still seeing those patients in the office. But I know some providers, depending on your relationship with the patient, are feeling more comfortability doing that. And I think that really is provider dependent. And certainly if any of the other panelists want to weigh in, that would be nice too. I think Dr. Adams is muted.
Dr. Adams, could you unmute? There you go.
I don't think I'm muted.
Oh, there she is. Okay, we can hear you now.
You know.
Okay. I would agree. I think it really is patient by patient, and depending on the relationship that a provider would have with them and their risk factor. Absolutely. You know, I can think of a situation where I have a patient who is an older young adult that I'm still caring for, who has a tracheostomy, and because of their genetic disorder gets recurrent ear infections. The parents are very well aware of what his symptoms are like. And so we absolutely know how to treat that over the phone and or even in a telehealth visit. So I think there's situations where it could work, but I think those are absolutely very specific.
Yeah, great point. And then I think we addressed our second question, that is it appropriate to do well visits via telehealth? I think, you know, one is we're not really seeing, and maybe we'll see this to come, but not quite sure, that we're getting reimbursed for those from our insurance companies. But I still feel like there is a great deal of benefit of seeing that patient, laying hands on them, doing those in-office screenings that are really difficult to do via telehealth. So I think, you know, if there's, you know, chronic conditions, it's very appropriate. As far as the true well child care, I think some of the things that we do with that are really difficult to do. But again, you know, technologies may change in the future. We may have different capabilities, but I think for the time being, we would much prefer to do in office.
I would, oh, I'm sorry. I would just like to mention one of the things that I did. I knew this was an older child who wasn't able to come in a month ago because they, you know, we weren't doing the older well visits, but they had some developmental delays, and I really wanted to follow up. So I said, you know, we did a telehealth just to make sure. I wanted to see what resources they were still using. We talked about what resources they could do online to continue to get some speech therapy online, and, you know, what were the teachers doing to help them with, to continue to get, you know, some of their assistance, even though they weren't able to go to school. So there might be situations where, yes, you can't do the well visit, but, you know, like Dr. Work said, there might be other things that it would be good to discuss in a telehealth visit with a EM code for a different diagnosis, but then say, okay, as soon as we can, we want to get you in then for the physical and the well visit at that time.
Exactly. And then our last question here is, what are current medical liability issues with telehealth? And it, you know, I think we're just continuing to see, I think some of the HIPAA compliance is one of the things that we are definitely keeping an eye on as far as monitoring that. Other things are just kind of patient privacy, you know, just making sure that we can ensure that for families. As far as other liabilities, I'm just kind of deferring to the other panelists too, to see if they've, you know, encountered any or had any issues with medical liability concerns.
I just wanted to mention one of the things that I didn't mention about the HIPAA and OCR compliance. This does not, with the platforms, this does not apply to just COVID patients. This applies to everything. So when they are saying that we're going to be about penalties and recommendations about specific technologies, they're talking about not just COVID, you know, COVID symptoms or situations. They're helping us to be able to see our patients for all their needs. So I did want to mention that there's no liabilities legally with the platform. So.
And I think most importantly too is that at the beginning of all these encounters, we should be asking for the parents' consent before we proceed with either a telephone call or a video call, just so that everybody's on the same page too. And I think document that, because unless you're documenting that, you're not. It never happened. As far as from an insurer standpoint or from a medical legal documentation standpoint. So there's just some food for thought on that. So. All right, and then I'm going to pass it off to Dr. Chamberlain.
And I don't know if there was one quick question in the chat box about, are there any regulations or recommendations about hospitals recording telehealth visits for peer review or quality improvement reasons?
That's a great question, Olivia. As far as recording, in my experience, we have not done anything like that. I think all that is recorded is what is documented in the electronic medical record. So, I know for the platforms for Facebook, the Doxing Me, and then the Zoom, those are traditionally not ones that are recorded. But if anybody else has had experience with that too, that's I think that's an interesting thing to really keep eyes on and keep track of. But for now, I think it's more so just the EMR documentation.
I do know that if you have to have consent, and the patient needs to be aware that it is being recorded. So if for any reason there's they cannot record anything without the patient's consent and obviously awareness.
Move to the next slide.
Hi, this is Dr. Chamberlain. Can you hear me okay now?
Yes, we can.
Dr. Chamberlain, we can hear you great.
Perfect. All right, so my job is to talk about, first thing I'm going to talk about is documentation. And the good news is that the documentation of a televisit is very similar to the documentation of a visit in person. There are a couple of things in particular that you need to document, though, in addition to what you would normally do. Number one is consent. We just mentioned consent. And consent, we've been doing both verbal and written consent. So we have a written consent form that we send out to parents, have them sign it and return it. Also do a verbal consent with every visit, just reminding them that it's a televisit and that there may be some problems with the audio or with the video. Also mention that it is the platform we use is HIPAA compliant. We use Doxy.me. And I also mentioned that there's no recording of the visit at that time. And then, of course, all that has to be documented in their chart. The next thing that needs to be added is place of service. I'm going to use this term a couple of times. Here, what I mean is where the provider is and where the patient is. So you just write that you're at your office, or I'll write that I'm at this office or that office, and that the patient is, typically they're at their home. So that needs to be documented as well. The contact, who are you talking to? Who's there for the visit? So simply saying, televisit performed with Johnny and his mom is sufficient for that. Time can be a factor when we're talking about coding and billing, and we'll talk about that in a couple of minutes. But if time is, if the majority of your time is spent counseling and coordinating care, then time can be used for coding and billing just as it would for an in-person visit. So make sure you document how much time you spent at the visit and how much was spent counseling and coordinating care. Some EHRs have little shortcuts and things to help with documentation. I believe Epic uses dot phrases. Each EHR is going to be different and unique, so make sure you think about that when you're thinking about your documentation. Can I have the next slide, please? Billing and coding. So the codes that we use for televisits are exactly the same as the codes we would use for in-person visits. The established codes and new codes that we're all so familiar with. The only changes we have to make are modifiers. So there are a couple of different modifiers that can be used for televisits. Most insurance companies want the 95 modifier. Some are requiring a GT modifier. I know that Ohio Medicaid does want a GT modifier. And then there's also a CR modifier. The CR modifier is specifically to be used in disaster situations, catastrophes, and some have likened our state of emergency to a situation like that. But in our experience, what we've seen is that it's been mostly the 95 modifier that most insurance companies want, although there are certain circumstances where they want the GT modifier. Place of service. So this is, again, sort of a different use of that term, and I'm sorry if that's confusing for people, but this is something that needs to be added when you are billing these visits. And by place of service, actually, typically it's always added, but typically it's the 11, which means that the visit was took place during or in an office. The 02 modifier is specifically for telehealth visits. This one is also sort of not unique to each insurer, but they have different rules and different rules apply. So you're going to have to talk to your insurance companies and see whether they want the 02 modifier or the 11 modifier. Ohio Medicaid has told us to use the 11 place of service with a GT modifier. But like I said, it depends on the insurance company. They have their own requirements and recommendations for which place of service and which modifiers that you would use. Telephone service visits. So there are some codes that can be specifically used for telephone visits. Up to now, I've been talking about telemedicine visits, which use both video and audio. If it's just a phone call with the family, then you can bill for your time and use these codes. I just noticed that the top code, the 99441, has an extra 4 in it, so don't add that extra 4. But that's for a visit that's 5 to 10 minutes long, and then the other codes are for longer visits. The one thing to remember about the telephone codes is that they cannot be used if the problem being discussed was from a visit in the past 7 days, or if it results in a visit in the next 24 hours. So talking to someone about a fever that they have currently that you saw them for a few days ago, you cannot use these codes for that. It's really for a new complaint, a new diagnosis, something that wasn't discussed or wasn't seen for in the past 7 days and not going to generate a visit in the next 24 hours. The G2012 code that's down there is a different sort of a code. It's not a CPT code. It's what's called a HCPCS code, which is a code that's typically used for supplies. That is a relatively new code that Medicare created, I believe, last year. I'm not sure if that would get paid by any carriers, but the telephone codes, the 99441 series, would be more appropriate for most telephone visits. Next slide, please. All right, payment, probably what many people are interested in. So we have a 9 pediatrician 3 office practice. So I have our experience. I've also spoken with our EHR company that deals with hundreds of pediatricians around the country. And personally, what we're seeing is that we are getting paid the same as an in-person visit. So we have seen parity so far. We've also seen parity as far as copays and deductibles. That for an in-person visit, if the insurance company would have charged a copay or applied it to a patient's deductible, that we are seeing exactly the same thing for televisits as we are for in-person visits. One thing that when talking to other people around the country, some people are experiencing some downcoding. And by this, I mean if you were to charge a 99214, a 99215, some insurance companies are only paying the same as they would for a 99213. So the same coding and billing standards apply for a televisit. So if you meet the criteria for a 99214 or a 99215, then I would appeal that and let people know that you're having issues with that. And I think I'm ready for next slide. All right, so some questions. So are there any billing or location restrictions? No. Because of the state of emergency, we have not seen any problems with location restrictions. Not exactly sure what's going to happen when the state of emergency is over, whenever that is. but that is something that we will have to pay attention to over time. Are all payers paying for telemedicine visits? So far, like I said, what we've seen is that they are paying the same as they would for an in-person visit. This goes for Medicaid, the managed Medicaid that we deal with, and the private payers. So we have not seen any problem with that so far. Liability, what are the current liability issues with telehealth? This has been addressed. I'm not a lawyer. I would say talk to your malpractice insurer. When we talk to ours, their only restriction would be not to see new patients by telehealth. This was something specifically that they mentioned to us. So, but seeing as existing patients is not a problem. Not exactly a liability issue, but we are in Cincinnati and we have some patients that are in Kentucky. So we applied for an emergency license in Kentucky. It was an easy process. So now we can do televisits with our patients in Kentucky without a problem. What is the appropriate coding and billing for a virtual well visit for patients over 3 years old? This is a hard question to answer because in the certain states that have approved well visits by telemedicine, the Medicaids that have, they've given specific directions as to how they want the visit to be billed. So at this point, as we have said, there are no payers in Ohio that we are aware of that are paying for well visits, so it's difficult to say how coding and billing would work for that. What is the payment for a video visit, telehealth versus a telephone visit? Well, payment is difficult to talk about because everyone's insurance contracts are different. The best way to talk about this would be RVUs, relative value units, and the what is it? So the 5 to 10 minute phone call is about 1/4 the RVUs of a 99213. The 11 to 20 minute phone call is about 1/2. So I would expect to be paid 1/4 or 1/2 of what you do for a 99213 if you do the 5 to 10 minute phone call versus or the 11 to 20 minute phone call. Last question here is, how is payment handled for both commercial insurance and Medicaid? I'm not quite sure. I think we've addressed that at this point. What we've seen, and I'm interested to see what other people's experiences are, but what we've seen so far is that we are being paid the same as we would for an in-person visit.
All right, and thank you so much, Dr. Chamberlain. Since we're running a little short on time, we're going to move on to Dr. Lucas, and then we will follow up with your additional questions in the chat box or following that. I know Dr. Adams had one quick slide before we get to Dr. Lucas. Thank you.
Sorry, I was muted. Just quickly, there's some considerations regarding should the patient be present and then confidentiality during adolescence. And really what I want to reiterate, which the other doctors have already reiterated, is we really want to try to make this visit as much like the in-person visit as we can and take advantages also of the benefits that we have of the telemedicine visit. And so what I like to tell people to do is, set the scene, explain ahead of time what the parents can expect before the visit, explain what they can expect during the visit, build rapport, and also, keep the child engaged so that they are kind of part of the visit as much as you can. If it is a toddler who just doesn't want to be part of it, maybe ask the parent to use a larger room or that the child can run around in so that they can still be part of, in a safe environment, part of the room. And then as far as adolescent confidentiality, this is still very important. And again, setting the stage ahead of time and letting families know how the office flow is going to be during the during the telemedicine visit, that you would like to have an opportunity to talk to the teen in a safe environment alone, but you'll start together, talk to the teen alone, and then together again, like you would normally do in your office visit, so that the adolescent has an opportunity to discuss with you confidentially.
Thank you, Dr. Adams. And Olivia, there we go. And we will toss it over to Dr. Lucas.
Thanks so much for having me. And I know we're short on time, so I'm going to try and just roll. You can go ahead to the next screen. A few things I've seen come up I want to comment on. I'm looking at the FAQ for Ohio Medicaid, and it does allow for telehealth for visits with new patients. There does not have to be a previous face-to-face visit. In regards to the well-child visits, the preventive care, we would love for that to be allowed, and we're working to help with that on a number of paths. And then as far as the patient needing to be there, there's been a real broad removal of restrictions on telehealth, and I think that just in everything I read, that was not addressed. If there are, with the thought that there was a broad removal, we don't want barriers. So if I could get feedback on some of those, obviously I think it'd be rare because we want to bring the care to the patient. But if there's instances that would help explain that, I can certainly bring that to Medicaid and see what we can do there. I'm speaking for Buckeye, but really I think all of the health plans, and I hope you all know that we are mostly staffed by clinical people. And I'd say every clinical person at our health plan is previously in their clinical life taking care of Medicaid recipients. So helping with access to care, understanding the barriers is something we do every day. And telehealth certainly helps with that. So ensuring that our members receive the access, we are pushing daily. I'm getting emails now, how to increase the scope and scale of telehealth services. I think if we all do this right, then it will certainly be here to stay when this crisis is over, and it'll be one of those great stories and what's been a long, slow ramp up, but is obviously this is going to be a part of medicine in the future, and this should speed it up. Again, I think similar to all the plans, there's no liability for the members. We're providing telehealth coverage for any services that can be delivered virtually, lifting all prior authorization requirements there. Okay, next slide. And I think this is interesting, demonstrates that we've certainly seen an increase in the professional services in the telehealth setting. So going from the beginning of March here towards the end of April, you can see it, the visual there, how much that's increased in the medical side and the behavioral health side. And do I have another slide? So I think I've said telehealth is here to stay. Provides means to members to access healthcare right from their home, and eliminating the barriers that we know about. Some of this you all are aware of. I think adolescent well care, from a quality metric measurement standpoint in Ohio, we do poorly in this. And what an opportunity to have adolescents in front of people who can really help them. And I don't know, you know better than me. I think 80-90% of the content of those visits do not need the actual physical exam. Last thing I'll say, I was on a call at the beginning of the day with community health workers that we work closely with that are in the really the highest risk zip codes across the state. And what they're seeing is apprehension from patients and really needing an introduction or a prepping of the patient before they have the telehealth visit. And that's kind of really allowing for successful visits and otherwise that they certainly may not happen. So just put that in. I believe that's my last slide, or no, I want to leave time for questions. Does CMS or other insurers have any framework in place to evaluate the effectiveness of pediatric telehealth programs and quality metrics? Not that I'm aware of, but that's great. And you can certainly imagine how much we will start to look into this, not me, but I think much more on the academic side, We're going to have a wealth of claims information. You all will have outcome information. We've got our own little lab here that we're really going to learn and see what happened. It is really interesting to me if I worry about, postpartum visits is something that's important in Ohio. We don't do wonderfully in that. We've worked so hard on it, and this is really going to be making that more difficult. But that's another setting where telehealth can I think serve a role and get us to a better place after this. So I guess it's to be seen, but I think we'll all learn and show how we can improve quality. Thank you very much.
I'd just like to add that there has been a few articles that I ran into in telepsychiatry and behavioral health in use of telemedicine, although there's really not a lot of research in that, but they have found it to be effective because patients are gaining access, they're feeling more comfortable versus coming to the office and sitting in a waiting room and feeling like, who sees me sitting here in the waiting room. But that was the only thing that I was able to really find prior to all of this. So I think the research as far as the effectiveness is to be seen.
And in the last few minutes that we have, Olivia, if you could just go back to the previous slide, we just have a minute or two. But I just wanted to draw folks' attention to the chat. If you haven't seen that, there's some great additional suggestions there for confidentiality for adolescents. And we've had a couple of follow-up questions that I know we will get additional information on. About reimbursement for well visits for infants, particularly at 1 month and 9 months when vaccines are not given, how to deal with the shortfall on quality benchmark payments. So we'll keep chatting through those in the chat box and then also follow up with you via email on answers to these additional questions. Just wanted to, in the last little bit that we have, again, thank everyone for joining us and the panelists and draw your attention to an Ohio AAP webpage that has up-to-date COVID-19 resources. And again, everyone will be getting access to the slides. Next slide, please, Olivia. And then also just to let you know, we will be having webinar number 2 in this series coming up in 2 weeks on May 13th, same time, same place. 12:15 lunchtime seemed to be kind of the time that works best for folks, and we will be recording all these. So again, if you can't join us, there will be recordings, and that webinar will be keeping patients, practices, and selves healthy, challenges and opportunities in pediatrics during COVID-19 and beyond. So be on the lookout for a registration link for that, and also follow-up email with this recording and answers to the questions. And Olivia, if you could take us to the next slide. This is just a reminder to please follow us at all of our social media sites where you can keep up on what the chapter is doing around advocacy and all kinds of great resources, news, and information. And with that, I know we were at the 1:15 mark, but I just wanted to give any of our panelists a chance to give any closing remarks and we can sign off. All right. Well, thank you everyone for joining us, and everybody have a great day. Stay well.